Hello and welcome to this podcast by the Podmedics. For other similar podcasts, supporting materials and book reviews, please visit www.podmedics.co.uk. Hello and welcome to this second podcast on the emergency diagnosis and treatment of arrhythmias. During this podcast, I'm going to attempt, within the next 15 minutes or so, to outline the basics of the tachycardias. While this is clearly a large and complex topic that is often made larger and more complex by some of the textbooks, as long as you have a good approach to thinking about it, it is quite amenable to reason and memory. So first, and perhaps most importantly, a tachycardia can be defined as a heart rate above 100 beats per minute. The most important and common type of tachycardia is, of course, a sinus tachycardia. This is often seen in the emergency situation in association with shock, say with fluid or blood depletion. In this case, the raised heart rate is an appropriate response that importantly precedes any drop in blood pressure. As this tachycardia has its origin within the sinoatrial node, we clearly see on the ECG a P wave preceding each QRX complex and a T wave following each complex. So what are the other tachycardias? The best way to think about these is to divide them into narrow complex and broad complex. And what we mean here is, what is the length of the QRS interval? Is it greater than 0.12 milliseconds or 3 small squares on the paper, and therefore broad complex, or is it less than 0.12 milliseconds or 3 small squares on the ECG paper, and therefore narrow complex? Next, we need to decide, is this broad or narrow complex tachycardia regular or irregular? Let's start by considering what possible arrhythmias fit into the narrow complex category. If the QRS complex is narrow, this implies that the cardiac depolarization has effectively used the His and Purkinje conduction systems. The problem therefore lies above this point, i.e., it is supraventricular. If the tachycardia is irregular, then this is atrial fibrillation. In this condition, there is chaotic electrical activity in the atria that occasionally and irregularly is successfully conducted through the atria and into the ventricles. If the rhythm is regular, then this is either a sinus tachycardia, as we said, with a P wave before each QRS and a T wave after each QRS, or if there is no P wave before each QRS, an AV nodal reentrant or an AV reentrant tachycardia. So briefly, and I don't particularly want to get bogged down in the complex electrophysiology of these, in AV nodal reentrant tachycardia, there is a localized reentry circuit set up within the AV node such that there is repeated activation and thus firing of the ventricles. While in AV reentrant tachycardia, there is an additional accessory pathway that occasionally allows depolarization to spread between the atria and the ventricle. The most common type of AV reentrant tachycardia, and the type that we really need to know about, is Wolff-Parkinson-White syndrome. Although there are two types, the most important features to remember are a short PR interval and slurred upstroke on the QRS complex, otherwise known as a delta wave. So those are the basics of the supraventricular tachycardias. The ventricular tachycardias are easy to remember as long as you realize and appreciate that a wide QRS complex either indicates that the problem lies within the ventricle, so as either VT, VF or torsades, or may possibly be of supraventricular origin with a bundle branch block, meaning that conduction down the His system is ineffective. Therefore, if you see a broad complex tachycardia that is regular, this is either tachycardia caused by an irritant bit of ventricle becoming the primary pacemaker, or any of the regular supraventricular tachycardias with a bundle branch block. For those that are interested, the way to tell the difference is to look for capture beats or fusion beats. Capture beats are paroxysmally occurring narrow complex beats on a background of broad complex beats. These indicate lack of disease within the conduction system and thus that the rhythm is ventricular in origin. Fusion beats, on the other hand, are basically the same as capture beats but have occurred during a ventricular tachycardia QRS complex, thus creating a paroxysmal, abnormal-looking QRS complex on the ECG. So the important arrhythmias here are ventricular tachycardia, ventricular fibrillation, and torsade de pointes. They're easy to tell apart. VT, as we have already said, is regular, and the QRS complexes are all of similar amplitude. In torsade de pointes, however, the QRS complexes tend to be of differing amplitude. VF has a characteristic appearance on the ECG and looks like a child's scribble. In terms of investigations for arrhythmias, obviously the most important tool is the ECG. You should also bear in mind, however, that many arrhythmias, particularly ventricular arrhythmias, may be due to ischemia, electrolyte aberrations, particularly of potassium and magnesium, and also due to drugs. Paradoxically, often these are antiarrhythmics. Therefore, it is important, in addition to taking a good history and performing a thorough examination, to do bloods for U's and E's, cardiac enzymes, and magnesium. So, let's now move on to management. This is quite complex and is based around the ALS tachycardia algorithm, a copy of which can be found on the website. As with the bradycardias, however, the first question you ask is whether the patient is stable. Signs of instability include ischemic symptoms such as chest pain, backwards cardiac failure with associated congestion, shock with a systolic blood pressure less than 90, or signs of cerebral hypoperfusion. If any of these are present, it's appropriate to electrically cardiovert as soon as possible. This always requires sedation and specialist anesthetic input. Beware, however, not all patients with a tachycardia and the above features have a shockable rhythm. For example, you don't want to be shocking a patient with a sinus tachycardia that, as we said earlier, may be due to blood loss or fluid depletion or any other causes of shock. So, let's say that the patient is stable. You then want to decide if they have an SVT or a VT. You would of course do this using the methods that I've already outlined. If they have an SVT other than atrial fibrillation or atrial flutter, then you would consider using vagal maneuvers, such as carotid sinus massage or the Valsalva maneuver. These are safe and often effective. If these fail, however, you'll want to give adenosine to cause a transient AV block. This is typically given as a 6 mg bolus and is always followed by a saline flush. It may be repeated 3 times every 1 to 2 minutes, with the second 2 dosages being 12 mg and 12 mg. Bear in mind and warn patients that they will feel transiently extremely unwell, and also bear in mind that this treatment is contraindicated in asthmatics due to a risk of bronchospasm. Once normal sinus rhythm is restored using either the vagal maneuvers or adenosine, you want to do an ECG prior to discharge. This is to make sure that the cause of the SVT is not Wolff-Parkinson-White syndrome, as this will need further treatment with ablation. Remember the features you're looking for with Wolff-Parkinson-White. These are a short PR interval and delta waves. The management of atrial fibrillation and atrial flutter is complex, and I've decided to do a separate podcast of these at some other stage. So finally, let's talk about the basic management of the broad complex tachycardias, particularly VT and torsades. VF is obviously treated with electrical cardioversion and will not be considered here. If a patient is stable and in VT, then you convert using amiodarone. This is usually given as 300 milligrams over around an hour, then 900 milligrams over the next 24 hours. If this fails, then this is appropriate to try DC cardioversion. Torsades, although really a type of VT-VF cross, is treated with magnesium sulfate and correction of any underlying cause. So, in summary, the most common type of tachycardia is one originating from the sinus node. This obviously should not be treated as an arrhythmia, but requires correction of the underlying cause, e.g., say, fluid replacement. Tachycardias due to cardiac disease may be either narrow complex or broad complex, and further subdivided into regular or irregular. The most important regular narrow complex ones are SVTs, either due to nodal reentry or AV reentry. These are treated with vagal maneuvers or adenosine. The most important broad complex regular tachycardia is VT, and this is treated with amiodarone and DC cardioversion if unsuccessful. AF is complex and is usually a narrow complex, irregular tachycardia, the management of which I shall consider in another podcast. So that completes this podcast on tachycardias. I hope it was useful, and thanks for listening. Thanks for listening to this podcast. Please visit our site at www.podmedics.co.uk for more podcasts and additional supporting materials.